Good morning. Thank you to the organizers for inviting me to this very prestigious conference. I have Mumbai roots. I grew up here, so it's always comforting to be back to the sights and sounds of my childhood. The topic that has been assigned to me is the sequential application and monitoring of mechanical support in the failing heart. The patients that we will be discussing for the next 24 minutes or so are patients who have refractory heart failure. So we've heard the definition of refractory heart failure, but just to reiterate, these are patients who have both signs of low perfusion and an organ dysfunction, as well as symptoms of inability to exercise, shortness of breath, along with imaging findings of low EF, elevated pro-BNP. All of these people are in refractory heart failure despite medical therapy. This is a problem because as the United States population ages, the number of patients that are entering into the category of heart failure has gone up exponentially in the last 10 years. And apparently, heart failure is an equal opportunity offender. It affects both men and women alike, and you see the category of both men and women in the classification of heart failure has increased. Furthermore, what you notice is that it has an age preponderance of greater than 60. These patients, again, are more commonly seen with heart failure in the United States. Heart failure is both an expensive problem and a morbid problem. It can cost upwards of $100,000 per patient per year. That's a pretty big problem to have and a very expensive one. In addition, you see that the mortality in these patients is greater than 50% at 5 years. So when you think about heart failure, there are 4 stages that are encountered: A, which is asymptomatic, and D, which is refractory heart failure. And stage D heart failure are those patients, again, which have NYHA class 3B symptoms and higher. For the sake of mechanical circulatory support, the Interagency Registry of Mechanically Assisted Circulatory Support has defined these NYHA classification patients into 7 categories. It's grade 1, which are the sickest, cardiogenic shock, they're going to die within a few days, and then stage 7 or Intamax 7 who have stable heart failure, who are sort of being treated with everyday therapies. Why is this classification important? This classification is important because initially when VADs were placed, they were placed in NYHA class 1 and 2. So these were the sickest patients that got the VADs. However, when we looked at the data on these patients, you notice that the patients that were Intamax 1 and 2 that got the VADs had a higher incidence of mortality than those patients who were Intamax 3 and 4 who had a lower mortality and therefore did better. Similarly, when you look at patients and complications, you see that the incidence of complications in bleeding or RV failure or end organ dysfunction seems to occur more in patients who are Intamax 1 and 2 who've had ventricular assist devices placed. With this knowledge, what you find, therefore, commonly, these are the kind of algorithms that are now being used in determining who should get what type of therapy. So first, when you have a patient with advanced refractory heart failure, they would fall into 3 categories. The first one would be listed for heart transplant. We'll talk about that in a few minutes. The second group are the patients who are the sickest, Intamax 1 or 2, or acute cardiogenic shock, which probably would benefit from short-term mechanical circulatory support. And these devices are your balloon pumps, the tandems, the impellas, and of course, ECMO. And the reason to do that is so that once they stabilize and are not dying anymore, then you can evaluate them for either a heart transplant or a ventricular assist device. So this is a very important category. And then the last category you see are patients who are ineligible for transplant, who however, have a better quality of life if they just had a ventricular assist device. And these are patients who are qualifying for destination therapy with the VADs. So let's first look at short-term mechanical circulatory support. These are the 4 percutaneous devices that are available for short-term support. The first one is familiar to everyone. It's a balloon pump. And the ones in the middle are just the LV, the short-term LVADs, which are the tandems and the impellers. And the one on the right provides both cardiac as well as respiratory support, and it's ECMO. Let's look at how these devices are placed. Again, going from left to right, you see the balloon pump is placed through an artery, either a femoral artery or an axillary artery. It is placed in the proximal ascending aorta. It provides modest support, so it requires the heart to work. The 2 in the middle are the temporary LVADs, The first one is the impeller, which requires only an arterial cannula. And then the next one is the tandem, which requires both a venous and arterial access. And the one at the end is ECMO, which provides both cardiac and respiratory support. And you'll notice that the ECMO can be configured in various ways depending on the surgeon preference, institution preference, as well as whether the patient needs to walk and how urgent is the placement indication. If you look at the amount of support provided, you notice that the IABP, again, provides modest support. It's a small cannula. It's about 8 French or so. It's placed in the femoral or sometimes the axillary approach. It provides about ½ liter to 1 liter of support. And since it's a small cannula, you notice that it has less incidence of limb ischemia, and so is less morbid, so to speak. And it requires a little bit of anticoagulation, not full anticoagulation. In contrast, the impeller, tandem, and the ECMO require much bigger arterial cannulas. The impeller comes in 2 cannula sizes, the 13 French and the 22 French. The 13 French provides 2.5 liters of flow, whereas the 22 French cannula provides about 5 liters of flow, just as the tandem and the ECMO. What you notice, again, in this table is that as the arterial cannula size increases, the incidence of limb ischemia increases as well. Physiologically, these devices act a little bit differently. The balloon pump is the only one that provides some amount of coronary perfusion. Again, like we said, the balloon pump needs some heart function to be present for it to work and provide adequate support. The other 3 devices, the impeller, the tandem, and the ECMO, all unload the LV and improve tissue perfusion. The goals of short-term therapy are therefore the following. 1, it prevents certain death, meaning you keep the patient alive for another day. You see what the end organs do with the improved perfusion. You see whether they can qualify for a heart transplant. If not, then the next step would be to give them a ventricular assist device. What you see on the right is our centrally cannulated ECMO patient who we had on ECMO for about 90 days or so before he got his heart transplant, and he did very well. He's in fact back in school. So moving on now to definitive or long-term therapy, let's talk about mechanical long-term devices or heart transplant. For the next few slides, I'm going to mention some of the nuances of heart transplantation. Heart transplantation remains a class 1C therapy for refractory heart failure in selected patients. This is important because there are a long list of contraindications to heart transplantation. Major ones are irreversible organ damage, such as kidney, liver, or lung, unless you're doing concomitant organ transplants. advanced pulmonary hypertension, and malignancies within 5 years, because they will come back with the immunosuppression that's required for transplantation. The ones in blue are the relative contraindications that include cerebrovascular disease, presence of peripheral vascular disease, age greater than 70. However, this is a moving target. As you know, Dick Cheney got a heart transplant most recently. Lack of social support. This is important because patients who don't have a good support system are not likely to take the immunosuppression, and then therefore they may die of rejection. So why is heart transplant not front and center for heart failure management? So the reason is this: even though you saw that the number of patients that are qualifying or coming into the scene with refractory heart failure goes up, the number of organ transplants has remained pretty much at a plateau. About 3,000 heart transplants are performed a year in the United States, and this is because of organ paucity. And there's also a long waiting list for patients who have blood group O, which is the commonest blood type in the US. So if you are blood group O and have refractory heart failure, the amount of time you could be waiting for a heart transplant could be up to 2 years, and you could succumb to complications. Hence, some alternative needs to be provided for these patients. The interesting fact that's also coming out of the organ procurement data is that since the last 12 years or 15 years that we've been doing VADs, you see that the number of patients that are presenting for heart transplant with VADs keeps going up, whereas the ones that are presenting without VADs keeps going down. So the bridge to transplant pipeline is definitely robust and increasing. So that brings us to the middle space. You saw that there is a robust therapy for acute cardiogenic shock, and then there are the group of patients that need the heart transplant. But since the waiting time is so long, what you find is that there's an empty space, and this study by Rose and colleagues catapulted VADs to the frontline stage. And what they showed here in 2001 was that patients who had LVADs did remarkably better and had greater survival benefit than those patients that were in the medical therapy category alone. Similarly, or rather, when we first did VADs, we used devices. The devices now that are being used are continuous flow devices. And what you notice is from this study is that, again, with continuous flow devices, the probability of survival increases in contrast to those with pulsatile flow devices. Furthermore, this single-center study by Park and colleagues demonstrated that with continuous flow VADs, there was improvement in symptoms, so there was a lifestyle benefit. So these patients returned to NYHA class 1 or 2 as early as 6 months and remained in that category up to 2 years, which was the duration of the study. Furthermore, they're able to exercise better. So what does that mean? That means that these patients who are waiting with VADs and are waiting for a heart transplant are able to walk around, are able to eat, are able to exercise. Therefore, they become more robust candidates for a heart transplant. So again, big survival benefit. Patients with VADs who go for a heart transplant do better, in fact, than patients who do not. Of the continuous flow devices, the 4 main ones that I will be talking about are these are the first 2. These are the HeartMate 2, which is approved for both bridge to transplant and destination therapy in the US. And the HeartMate 3, which is approved in Europe, still in the study stage in the US. These are owned by Thoratec, now part of St. Jude. The competitor for the HeartMate 2 is the Heartware HVAD, which is now owned by Medtronic as of last month. It's a intrathoracic device. and is gaining popularity. However, it has only been approved for bridge to transplant, has not yet been approved for destination therapy. The one on the right is an interesting device, although it's not mainstream yet. It's the Reliant Heart. The cool feature of it is that it has a flow probe on it, on the outflow cannula, which goes into the aorta. And it measures direct flow versus the other VADs, which actually measure flow as an algorithm. Again, for the sake of repetition, inflow and outflow cannulas are with respect to the VAD. So the inflow cannula goes from the LV into the VAD, and the outflow cannula goes from the VAD into the aorta. So that's what inflow and outflow stands for, as I'll be referring to them more commonly. For the next 3 slides, I'm going to talk about the anesthetic nuances of LVAD. These are the sickest patients you'll see in your operating room. The induction is meant to be cardiac specific. I recommend no particular drug. It's just important to keep in mind that these patients are very sensitive to hypotension, which will cause RV dysfunction, as well as they are very sensitive to hypoventilation, which will also promote RV failure. We do a pre-induction A-line. We use radial and brachial lines interchangeably. We have a low threshold for use of ultrasound for line placement. Some of our sicker patients, we do a pre-induction balloon pump. We've had mixed results with it. There's no clear indication for this anywhere in the data that I've seen, but we seem to get away with it ever so often. We routinely use both a PA catheter and a TE, and all of our cardiac surgery patients get cerebral oximetry monitoring. These patients are done on cardiopulmonary bypass with a cross clamp, and post-bypass, we use an inhaled pulmonary vasodilator. Our institution uses epoprostenol. That's what's the cheapest to us. We have tried inhaled milrinone. However, it's very difficult and labor intensive for us to manufacture, so it's not very popular with our ancillary staff. A beta agonist is a must, as you can imagine. Anywhere between 50 and 150 nanos per kilo per minute is recommended. And then a vasoconstrictor. This is key because the RV is perfused in both systole and diastole. Hemodynamic goals are simple. Keep your MAPS up, keep your CVP down, and that's the key to RV management. The 4 things you will discuss with your surgeon before he does the VAD is if there are mechanical valves that need to be replaced with bioprosthetic valves to decrease the possibility of thrombus. A PFO needs to be closed. If there's more than moderate AR, that needs to be addressed. What's controversial on this is what do you do with moderate TR? 5 years ago, when I was doing this talk, it was everybody that had moderate TR had a dilated annulus, had it repaired. Now, for VAD patients, it's not clear because we've now come to understand that TR is more of a dynamic process. So there's no clear, it's more of a institution or surgeon-specific issue. What are some of the echo things that you will help your surgeon with? One is cannula placement. This is your ventricular inflow cannula. It goes at the apex of the ventricle. It's placed from outside to in. So your surgeon's going to need your help in terms of directing the cannula. What's recommended is that there be laminar flow from the mitral into the cannula. You don't want the cannula to be directed towards the septum. Again, in patients who have small LVs, you'll find that this is an issue because no matter how careful the surgeon is, there'll be some direction towards the septum, and that'll cause propensity for suction events. If you were to use CW, again, this will give you an idea that this is laminar flow. It's going from the mitral into the inflow cannula. The surgeon uses a little graph that he will attach to the proximal ascending. This graph sometimes is prone to kinks and twists. So identifying laminar flow in this aortic cannula is also key. And you can see this in one of 2 views. This is your first view, and then this is your second view where you see the cannula up here with laminar flow. The most important thing that you're looking for after an LVAD is RV dysfunction. Making sure that the RV is nice and small is important because that'll improve your success with an LVAD. The LVAD does three things. It unloads the LV, it decreases the amount of TR, it decreases your pulmonary vascular resistance, and therefore it should improve RV function. But in 20% of the patients or so, you will find this. Dr. Tempe did a fantastic job with RV failure, so I won't belabor you with the details. But essentially what you see here is the septal flattening, presence of a moderator band, and a nice wide open tricuspid valve with RV failure. RV failure is a bad thing. In patients who have LVADs, it decreases lifespan with the presence of RV failure. Just the diagnosis of RV failure increases mortality and morbidity in these patients. This is one of the largest studies done in the HeartMate 2 population, where you see the three things that are most likely to be associated with RVADs. That's ventilatory support, an elevated CVP, a low wedge, and presence of BUN greater than 39 or kidney dysfunction, which is also a corollary of increased CVP. So why does it happen? It happens because either you turn the LVAD up too quickly, the septum got sucked into the LV, and there was loss of septal contribution to RV contraction. It could be that the LVAD improved cardiac output so much that now the RV is unable to handle it. It's possible that the patient is bleeding and you need to resuscitate, causing, again, volume overload. And then finally, presence of arrhythmias will affect RV perfusion. You need to aggressively go after these 5 things in patients immediately after LVAD implantation. So do not turn up maximally your LVAD speeds, gradual inotrope wean over several days. Make sure you remember the lung component to it during your inotrope wean, aggressive arrhythmia control, and diurese. If all else fails, again, an RVAD. So this is a study which looked at a percutaneous RVAD device. This was approved in 2013. It's done by fluoroscopy. This is the tandem RVAD. What you see here is this is your RA cannula, and this is your PA cannula, which is inserted either from the femoral to the PA or from the IJ to the PA. And this has some success. What you see on echo is the presence of the RVAD, which is just proximal to the pulmonic valve. You don't want it to be too far in, otherwise it won't work. You can use implantable RVADs as well, and what you see here is a intrathoracic device which is placed on the RV. So do RVADs improve outcome? The answer is a resounding no. Not just is RV failure associated with increased morbidity, but the fact that putting patients on an RVAD will also increase their mortality or decrease their survival benefit. What you see here is from the Columbia study, where you saw the survival with RVADs at 40%, with no RVAD, 80%. Now you ask, does it make sense to prophylactically put an RVAD in patients at the same time as an LVAD in people who you're worried about, or do they get the same benefit if you put the after LVAD implantation? The same study looked at the survival difference, and again, so no difference in timing, whether the RVAD was placed at the time of operation or placed a couple days later. So to conclude, heart failure is a bigger problem in countries which see aging populations as we do. Therapy for refractory heart failure should include both short-term, long-term, as well as heart transplantation. Short-term therapy plays an important role because it'll allow the patient to declare themselves and figure out whether we can either mitigate their end organ dysfunction and put them in either the bridge to transplant category or the destination therapy. Heart transplant remains a goal, the gold standard, and is a problem because of paucity of organs. Continuous flow devices are the only way to go now. presence of RV failure increases mortality, as I showed you. And then if someone gets an RVAD, they are more likely to die than if they don't. Thank you very much for your attention.
An excellent presentation, Dr. SHEELA. Mechanical cardiac support in India is still not very popularly used because of the cost constraints. And wherever it is used, there are again evolution in the rest of the world from the now it is continuous flow devices, heart port 3, which is having less complications, whereas the other ones. So the changing scenario makes it even more difficult to implement in different places. We had recently experience with the team coming to for heart port 3, and I want to ask whether there is a complication of fluid management at the end of the surgery, making it difficult to close the chest, and we kept the chest open for some time, and there was a lot of difficulty managing fluids for heart port 3. Maybe the patient eventually went into right heart failure and it was not successful. Can you comment?
So what you bring up is a very important point. People who are small, so in India where the average person is a small person compared to the US or even in Europe, this is going to be a big challenge, because to get an intrathoracic device, you need there to be enough room in the thoracic cavity so that the device can sit properly and then close the chest. And we've had this situation with some of our very small patients, adult patients, who we've had to leave the chest open only because they've been bleeding. They need to be resuscitated first, and then they need to be diuresed, or fluid has to be removed for the next few days, and then we've closed the chest much later once we've dried them out. In these patients, we've used RRT or CRRT early on, even if they're not in renal failure, with the idea that you can't actually remove as much fluid as you would like with diuresis alone, but with CRRT, definitely you can take off as much as you want, even with a slight amount of vasoconstrictor use, and that allows us to close the chest. Also, the other thing is to consider what is their fluid status when they come in. Some of these heart failure patients are so volume overloaded that unless they're ultrafiltered aggressively on cardiopulmonary bypass, you'll just find that you're adding to the problem by resuscitating bleeding. So we aggressively ultrafilter on bypass as well.
Are there any other questions from the audience? I have a small thing about the management of heart failure patient with a synchronization of right ventricle and left ventricle pacing. Are there any pitfalls in that, your experience?
Besides device-related complications, you don't see any pitfalls. I mean, the device-related in the sense infections and scar formation and all of that. We've actually implemented CRT, or cardiac resynchronization therapy, in most patients who have an EF less than 30% and who have interventricular conduction delay. Those two things are absolutely required before we recommend them for CRT. And most of our heart transplant patients do come in with pacemakers and defibrillators in place, because you'll find that it definitely will decrease the amount of sudden death that you see with these patients going into arrhythmias.
Thank you. If there are no other questions, is there? Okay.
But we still do roughly around 30 LVADs a year, 25 to 30. Last year, since last about 13-14 months, we've been doing only HeartMate 3. But a lot of these elective scheduled LVAD insertions, they are admitted quite before in the ward, and we do not take them, we do not list them until the CVP is below 10 or 9 or in a single digit. So aggressively diurese, some might be just with a diuretic therapy, or somebody might be pre-operatively either CRRT or intermittent dialysis, but they are quite dried out.
Yes.
Before
Absolutely,
even
that's
coming to
key.
the theater. Secondly, before or at the time of weaning from bypass, our protocol is we start nitric oxide for every case. And so far, at the moment, we haven't required any open chest so far, touch wood and no.
So, INO is a bad word in the U.S. The way INO payment structure or reimbursement is that every time someone uses INO, the money goes directly to MGH. It doesn't go to insurance, it doesn't qualify for insurance reimbursement. So as a result, people are going away from INO. And in our institution, we have a spectrum of surgeons and preferences. And some of our older surgeons still like INO, and some of our younger surgeons don't care either way. And what we found by just looking at the data is when it comes to RV failure and use of Flolan versus INO, we've had comparable results. It's not been that INO is that much better. It's just more expensive, and therefore you get sort of flagged.
Any other questions? I want to ask one question about inhaled pulmonary vasodilators and comparison between inhaled nitric oxide and prostacyclin. I don't know whether anybody uses. I have not used inhaled prostacyclin, but we had good results with nitric oxide. Milrinone, as I thought it was not very predictable effect, I could not see. Others we have not used, but it is said that inhaled nitric oxide is more expensive than prostacyclin, and then why we are not using prostacyclin, I don't know. I don't have the answer.
At least in the US, I can speak to the cost issue. I don't know what the cost differential is here, or even in Singapore for that matter. In the US, there's a remarkable price difference between INO and Flolan. Flolan is like dollars, whereas the INO is like thousands of dollars. So as a result, we've not been able to justify INO use because we've not seen spectacular results with INO. So we've moved away from that. But that's, my sense is that both these drugs are equivalent, and they work either way. I think the inhaled prostacyclins have less systemic side effects. So you find that in contrast to IV milrinone, for example, it'll be a bigger problem with systemic hypotension.